Good afternoon, and thank you everyone for attending today's webinar. Are you leaving money on the table? Brought to you by Rich Papperman of Cape Professional Billing. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following the completion of today's webinar, and a recorded version will be available on the website for members only. Again, NJMGMA would like to thank you for attending, and I will now turn things over to Rich.
Good afternoon, or if anyone's joining us from the central or further west time zone, good morning. We've been in business about 27 years, and we've been surprised at the number of practices that are not providing very many, or in some cases, any preventive services. So there are some significant opportunities with preventive services with Medicare and other commercial payers. And what we've found, of course, is that the insurers are essentially focusing entire armies of people using high-end computers with sophisticated software, and as all of us will appreciate, they're dedicated to finding ways to deny payments to our clients or to our practices. So 3 things we'd like to cover today. Which Medicare and commercial preventive services are you already providing but perhaps not billing for? Which are available that could be billed for but you're not providing now? And third is taking full advantage of the annual wellness visits, both Medicare and commercial. At the end of the presentation, we'll talk a lot about the financial side of this. But I don't want to miss the fact that the real benefit is to the patient and the patient's health, finding things that may not have been found yet, and treating things in a more comprehensive way because they're now being paid to do that. As we go through the presentation, there's a theme on some of the slides called primary care setting. And I wanted to just give that definition now to make it a little easier. Primary care is, in its fancy definition, is one in which there is a provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. I think the simple way to say that is that's what a primary care physician does. That's what they're trained to do, and the old term we used to use is sort of the captain of the patient's health. There are 7 areas that are specifically mentioned as not being considered primary care settings. So an emergency care physician, for instance, in the emergency room or the emergency department of a hospital would not be able to provide some of those services. Inpatient hospital settings and so forth are also included. To make it a little easier to follow, I've tried to color code that so that when you see pink, we'll be referring back to primary care. The first preventive care program is called the Initial Preventive Physical Examination, also called IPPE, and it's specifically for new Medicare beneficiaries within the first 12 months of their first Medicare Part B coverage period. We have to keep in mind that patients can opt in and out of the traditional programs, and so if they were in a traditional program and then opted out to an HMO and then back in, they don't get to have a second IPPE the next time they go back in. But it is a once-in-a-lifetime benefit, but no later than 12 months after the effective date of coverage. The amount of payment, though, is substantial. It's $180, and that's a nice chunk of change. When we look at the total effect of this program at the end of the session, at the end of the slides, you'll see that this can be quite a substantial amount of money for all the preventive services to flow into a practice. There's also an EKG that can be provided during that first visit, and the codes are very specific. Again, we've done some color coding. Green means that the copayment / coinsurance and deductible are waived, and if it's yellow, then the copayment, coinsurance, and deductible apply. So in this case here, the examination is covered completely, but the EKG has the normal copayments. Once they get past that initial 12 months, then they're able to receive the annual wellness visits, the G0438, G0439. Once again, the G0438 pays very nicely at $186, and all beneficiaries are eligible as long as they're not within the first 12 months and have never received an IPPE in the past. Once again, for both of these codes, the copay and deductible are waived. Don't want to forget that the commercial carriers also have some plans that have the wellness visits. So while we're covering Medicare primarily, I did want to mention that many plans are available with patients to receive that. However, it's really important that you check for benefits, because if a patient didn't pick one of the plans within their little smorgasbord of options each year, one patient from a, let's say, a casino may have a benefit, but another one may not. So you do want to check eligibility. But with the commercial plans, typically both are waived, and nice not to have to worry about copayments and deductibles. Alcohol misuse, screening, and counseling. Here's one of our primary care setting requirements. All beneficiaries are eligible to receive it, and it's interesting that you'll see this theme as well, where they talk about patient being competent and alert at the time of counseling. It's a bit amusing to think that they have to say that, but we'll see that as one of the recurring themes. Initial screening is 15 minutes, roughly $20, and then counseling is up to 4 times a year, $27.73 each. Once again, copayment and deductible are waived. We have a number of services for intensive behavioral therapy, in this case here for cardiovascular disease. Once again, we have the primary care theme kicking back in again, and you also see where it says competent and alert. So in any case, what we found is also fairly interesting is that we have a physician who is a cardiologist but has a significant primary care practice as well. Because of their definition, Medicare has taken the approach that he can't provide that service. Now, the odd part about that, of course, is as a cardiologist, who would be more competent to provide this counseling than a cardiologist, but they have specifically said no, primary care physician, and yet he has a primary care practice. So it's interesting that we're going to have to do a fair amount of appeals in order to fight this particular issue. Don't know that we're going to prevail, but we are going to go as far as the administrative law judge level in order to try to point out that a specialist can also have a primary care practice. Once again, the copayment and deductible are waived, and removes the impediment to receive those services. Counseling to prevent tobacco use. Once again, copay and deductible are waived. The differentiation is that they have to use tobacco. It's good to know that both smoking and chewing are covered, both forms of tobacco that are health risks, let's say. Once again, they have to be competent and alert at counseling. I guess I say that because I find it so amusing that it's a requirement. And then, of course, has to be required by a physician or Medicare recognized practitioner, which would be a nurse practitioner, physician assistant, so forth. Frequency they give is interesting also. They give 2 cessation attempts per year with 4 intensive sessions or intermediate sessions for each attempt, for a total of 8 sessions per year as an attempt to get them to stop smoking or give up chewing their tobacco. Obesity is, I think everyone knows that in the world, the United States is one of the heavier countries, I guess you might say, on a percentage basis. Good that Medicare has recognized that it's a program worth trying to establish. So if someone's body mass index is over 30 kilograms, that qualifies the patient. Once again, it's a primary care setting. 2 different codes to do that. If the patient is seen by a physician or a nurse practitioner or physician assistant for 15 minutes, $27.73. But it can also be done in a group, so a practice could put together a group of patients And once you get past having 2 on there in the room, you then get to the same rate for 15 minutes, but you're required to spend 30 minutes. So you really need about 4 patients to make it worthwhile. Do note that the ICD-10 codes are specific for this and many others of the preventive services. So if you have software that allows you to check for a valid diagnosis, you could add these valid diagnoses in here for the G0447 or G0473 to help make sure the claims go in clean and get paid timely. Frequency is interesting also. The first month, the patient's seen face-to-face every week. For months 2 through 6, 1 face-to-face visit every other week. And then months 7 through 12, there's a face-to-face visit every month if the requirements that we'll talk about here in a minute are met. The 6-month visit, a reassessment of the obesity and a determination of the amount of weight loss has to be performed. And they have to have lost at least 3 kilograms or 6.6 pounds, which does not seem unreasonable to make it. If there's not success, why would Medicare want to continue to pay for it? And again, the copay and deductibles are waived. The fact that they do that, of course, removes the impediment from a patient to say, I don't want to have this service because it's costing me money. So it allows the practice to provide that service in a way that hopefully will achieve the positive results for each of these preventive programs. Prostate cancer screening, again, is a bit interesting. The PSA test is covered deductible and coinsurance, whereas the digital rectal exam is not, and the copay or coinsurance and deductible does apply. Before I go too much further, one of the things that I was going to mention is that you can, in fact, try to minimize some of those services early in the year and provide them later in the year so that patients have met their coinsurance and deductible, which removes their concern. As probably many of the practices know, if you provide an office visit, they understand that that can hit the deductible and coinsurance. But some of these other services, the preventive services, patients often don't see the value in it. So providing those services a little later in the year once they've hit their deductible allows you to provide it and minimizes their concern about having to spend extra money. Pelvic examinations for our ladies differentiates into high and low risk patients. So if the patient is a high risk patient, then you can do it annually, and that's defined there under frequency. If it's low risk, then it's every 2 years for those ladies. Payment for it is about $42, and all female beneficiaries, of course, do qualify. Something that probably most practices do provide are the vaccines, although not all of them do. I know in some cases they've decided it's too expensive. Medicare covers flu for all those variety of CPT codes. One thing that we have seen with some of our clients as we brought them on is that some of them often forget to bill for the administration. So for flu, the G0008 is an important part of it because often the medication cost is right about at the reimbursement, which means there's not much profit for that. But the administration fee actually provides a fair amount of profit, I think, and not big in numbers, but big in terms of a reasonable percent to cover the cost of the staff and the storage and things like that. Typically, they cover 1 shot per flu season. However, if a patient medically needs an additional flu shot, they will cover it. Obviously, the medical documentation needs to be pretty sound, particularly if the practice provides a lot of them. Medicare could, in fact, decide to do an audit. So you want to make sure medical necessity has been established. Pneumonia, another one that is typically provided to beneficiaries. Once again, a similar theme where they'll cover 1 per year, and the second one if there's good medical necessity. Hepatitis B virus, a variety of codes based on the dosage and age and so forth, particularly for intermediate and high-risk patients. Obviously of good benefit, not one that's highly used for solo practices, unfortunately. But again, make sure not to forget to use the administration fee, the G0010. New Jersey, that pays about $23, and there is no copay or deductible. So again, given that it's a something anyone's going to complain about. Depression screening is a little bit different, covered in the primary care setting, but it does require an office that has the ability to support the accurate diagnosis, effective treatment, and follow-up of these patients. So the screening itself is 15 minutes annually, but it's not apparently something that every primary care practice may be equipped to provide. Once again, copay and deductible are waived, and again, that's where it's helpful. Diabetes self-management training. Patients have to be diagnosed with diabetes, which is, of course, fairly logical. Have to have an order from a physician or a qualified non-physician practitioner who's treating that patient's diabetes. The reimbursement's not bad, $57 for 30 minutes. Typically, I would guess this is going to be done by someone other than a physician, but certainly a physician is trained and could do this if they chose to. If they do a group session, then they have to have 2 or more patients per 30 minutes. And once again, you need about 4 patients to make it equivalent payment-wise to an individual counseling session. Frequency is split up a little bit. The initial year, you can have up to 10 hours of initial training within a continuous 12-month period. And subsequent years, 2 hours of training after that. Co-insurance and deductible copays do apply. So in those cases where you have the copay, deductible, co-insurance that the patient has to pay, I think it's particularly important to talk about the importance of this and the value of this to the patients from an educational standpoint. They need to see the value of that cost, that training, and if they understand that, they're more likely to comply with covering those additional costs. And I think, as everyone knows, and I mentioned earlier, many people see the office visit as something they expect to pay, but beyond that, they begin to question things, and we need to provide enough education to help them understand that these new programs from Medicare, in fact, help their health, help their well-being, provide quality of life options for them, and we should not be embarrassed or reluctant to point that out to them. Medical nutrition therapy. Again, they have to receive a referral from the treating physician. Typically, are diagnosed with diabetes or renal disease, and or may have received kidney transplant within the last 3 years. And typically, these services are provided by a registered dietitian or a nutrition professional. They're going to talk a lot about what's good to eat and what isn't good to eat. Various codes there. We won't go into each of those. And the frequency, of course, is 3 hours and one-on-one the first year, and subsequent years 2 hours. This is probably more likely to be a small group practice or larger group practice where they have enough patients to group such a thing, or maybe a referral to a hospital that might provide the service for many physicians in that area. For those who may be working for an ophthalmologist or an optometrist, Medicare does cover glaucoma screening. The patient does have to have diabetes, have a family history of glaucoma, be an African American, age 50 or older, or Hispanic, age 65 and older. So any one of those will qualify them. And the reimbursement for an ophthalmologist or optometrist is a little over $60. Again, specific ICD-10 code is required. It's a simple thing just to make sure that you do get paid. If you don't, you'll get denied. The frequency of glaucoma screening is annually, and the patient again has a deductible and a co-insurance for traditional Medicare patients. May have one for HMOs, but very important that you again educate the patient to the value of this disease, the fact that it's a relatively silent disease, but can significantly damage their eyesight if it's left unchecked. So if they see the value in it, they'll have a lot less complaint about getting that bill for the copay. One of the procedures, the primary procedure, is the screening colonoscopies, the fecal occult blood test, the flexible sigmoidoscopies, and barium enemas, the various screening procedures. Once again, they split it into high and normal risk patients, but typically the categories age 50 and older are at normal risk, and for patients that are high risk of developing colorectal cancer, it's defined as in the Code of Regulation, which I gave you there, and it's a link when you get it. If it's a screening colonoscopy, there is no age limitation, so this is something that, again, is quite helpful. The normal risk, it shows the frequency of screening. I won't go down into all the details of that. I think that each practice needs to look at that. High risk has its own set of screenings, and once again, there's a bit of a split. The fecal occult blood, the G010405, and those other three codes, there is no co-payment or co-insurance, and deductible are all waived as well. The other part at the bottom that's actually kind of interesting, there's no deductible for any surgical procedure, and that's the entire range of surgeries from $10,000 to $69999. If they're furnished on the same date and during the same encounter as a screening colonoscopy, a flexible sigmoidoscopy, or a barium enema, which was initiated as a result of the colorectal screening. So I don't know that may not be a real opportunity, particularly for our surgery friends, physicians, to have something that's scheduled at the same time they found some other issue or other reason to do a surgery. And if you note, it even includes all the minor procedures, because it starts down at the 10,000 range. So you may well be able to pick up some surgeries that otherwise would have a co-insurance or a deductible. Excuse me, I think that's just deductible. So if someone who has a method deductible, you may well be able to get an extra service without having to try to collect any money for a deductible from a patient. For the folks who are primarily working with lab coverages, and we do have some primary physicians who actually have their own labs, it's interesting that much of this, of course, has no deductible or co-payment or co-insurance, and does talk about the various risk factors for Cologuard, for instance, and so forth. Cardiovascular diseases. Important to remember that if you're going to do this, it's only once every 5 years, and these are for beneficiaries without apparent signs or symptoms of cardiovascular disease. Of course, you have the lipid panel and some of the other tests there. Once again, make sure you use that specific ICD-10 diagnosis in order to get paid. The diabetes screening, of course, makes a rather significant amount of sense. As people already have been diagnosed as diabetes and not eligible. There's no reason to screen someone who already knows that. So this is limited to certain risk factors and cover the tests, the typical glucose tests. Frequency, of course, those with prediabetes, 2 per year, and 1 per year if previously tested but not diagnosed. Screening for cervical cancer with human papilloma, HPV, papillomavirus. All asymptomatic female medical beneficiaries, age 30 to 65. They have 1 code, and again, the frequency is about once every 5 years. Be sure to use the allowed diagnoses. Of course, make sure the patient qualifies for those, but make sure that you're matching the diagnoses properly. HIV screening coverage is for those who are increased risk for HIV infection, including anyone who asks for the tests or pregnant women. The various codes are there, along with the allowed diagnosis codes for the, and again, if you have software that you can set up to look specifically for an allowed diagnosis for each CPT code, you will minimize your, and for the most part, avoid any denials for all of these different codes we've talked about today. Once again, the frequency is down below. I won't bore you with reading it all, but be sure to reflect the requirements in the medical record for the various risk factors. Hepatitis C screening. Patient has to be high risk for HCV infection and born between 1945 and 65. Specific ICD-10 codes, just 2 of them in this case. Testing is annually only for high risk patients with continued illicit drug use, but once in a lifetime for other beneficiaries who are not considered high risk. We used to call them, back in my clinical days, STDs. We've now changed the wording, I guess, to sexually transmitted infections, STIs, and now we talk about high-intensity behavioral counseling to prevent them. For certain Medicare beneficiaries, when all of the following are true, the patient has to have been sexually active as an adolescent or adult, and then has a referral for a provider that's in a primary care setting. And you can see all the different CPT codes. I put multiple under ICD-10 codes because there were quite a few of them, and didn't see any value in listing them all here, but you can find it in the policy in the link at the end of the presentation. Screening Pap tests, all Medicare female beneficiaries are eligible. There's a variety, again, of codes depending on circumstances. It is important when you're doing the billing, if a patient is high risk, you've got to use those diagnosis codes in order to get paid every year when you bill it out. If you don't use the high risk code and you bill it 2 years in a row, you will get denied. You can low risk, for low risk diagnoses, you'll get paid every 2 years. So again, it'd be important to make sure your medical record, electronic health record, has a way of identifying when they're eligible for each of those services. A few radiology tests, screening mammogram. Again, you have the various CPT codes, one specific ICD-10 code, the frequency age 35 through 39 with one baseline, and age 40 and older annually. I think there's some comment whether people need them that often, but I think that's a clinical decision that the providers have to consider based on each patient's conditions. Lung cancer screening counseling and annual screening for lung cancer with low-dose computed tomography. Beneficiaries who are age 55 to 77. They're usually asymptomatic, and the history of smoking for at least 30 pack years. And of course, it's interesting when they define these things that 1 pack year equals smoking 1 pack per day for 1 year. 1 pack equals 20 cigarettes. So it all, there's an interesting calculation there, I guess, when we talk to our patients. And it also covers current smokers who have quit within the last 15 years, and they need a written order to have the screening, which is typical, of course, for all lab and x-rays and so forth. Not to mention referrals for surgeries that we've all dealt with and other procedures. 2 CPT codes. Once again, there's one allowed ICD-10 code and talks about the frequency of annually for Medicare beneficiaries. First year before the first lung cancer screening. I won't bore you again with reading these things, but all important things to consider. Ultrasound screening for abdominal aortic aneurysms. You have to have certain risk factors for AAA and receive a referral. There's one CPT code, but there are multiple ICD-10 codes. Typically get one in a lifetime, and again, it's a clinical decision. So now we're down to kind of the economic benefits. I'd like to think of it, though, as also patient health benefits. And I think that it would be a rare practice where it would not be very beneficial to the patient to have a thorough review of their well-being issues, if you will. Are they overweight? Are they smoking? Are they drinking? Doing other risky behaviors that hopefully can be caught and changed before they result in a bad ending. It would also be a rare practice where it would not be economically worthwhile if it's properly managed. there's a significant amount of opportunity here, I think. The payment should certainly cover the cost to provide this. I don't see how it should not if it's not done, if it's done well. Depending on how busy the practice is, it could even justify adding another provider or a nurse to help the early part of the process where the physician can do the higher level managing, or nurse practitioner or PA. In practices that are not overly busy, perhaps maybe have a few time slots available each day that don't get filled, this could easily fill those time slots with productive time for the practice. One of the things that you'll want to do, if this is a consideration, is to do an analysis of your patient population. What does your age range look like? Remember, every patient who's 64 will be 65 in the next year, assuming they don't pass. And that's an opportunity to do an IPPE. How many Medicare patients do you have in the practice? How many have not been receiving these preventive services, or how many could you add to that that maybe you are providing? And then look at the non-Medicare patients. How can you identify patients with HMO benefits or even non-HMO benefits that are also covering well visits? One of the things that we encourage all of our clients to do is do an eligibility check at the time each patient makes an appointment. That way you verify that they have coverage, and you can also look at the benefits and make a note what they might qualify for. And then when they show up on the day of the visit, when you're collecting your copay, you also want to verify the benefits again, particularly some of the casinos and some of the seasonal jobs. You want to make sure that that insurance is still in effect at the time of on the date of service. Now, we all know, of course, that the insurers at times don't have accurate records, but for the most part, that's not really true, even though we all grouse about how much we aren't happy with the insurers. But for the most part, of course, it provides decent information. And I don't know what the percentage is, but I would guess probably north of 90% of the time the insurance coverage is correct. And then if you find that they're not covered, it gives you an opportunity to tell the patient to have new insurance that's called CASH, C-A-S-H. So I wanted to try to provide a little bit of an idea of what the economic benefit would be for sort of a normal approach. So in the first IPPE year, if you provided some of the services that we talked about, and if you note they're not all there, but I felt like we'd take a sort of a representative sample, and then there's a couple at the bottom which not everybody would necessarily qualify for, but would in fact add to the top as well. So if you do the IPPE and the EKG, you do the cardiovascular and obesity screenings, look at the occult blood, check alcohol, tobacco, and prostate cancer or pelvic. For a male, you would earn about $314. For a female, about $334. And I took a sort of a gross average of about $325 for, say, 30 patients in a normal practice. It would bring you about almost $10,000 on an annual basis. Now, that's not too bad, but when you then look at the benefit of the first annual wellness visit, the G0438, and again, because many of these things are annual screenings and services, and I also took, if you note, the lower level of the code. So if there was a higher reimbursement for another code, I took the lower of the two. So for males, it'd be about $301 for that year. For females, about $321. Again, I used a low number of patients, about 30, to guess what that economic benefit might be. That's a little over $9,000. So just for these 60 patients, you'd be somewhere around $19,000 in that ballpark. Again, it could be a little higher, a little bit lower, but if they've never received these services, these are reasonably decent numbers. If they received a few of those, then you'd have to just kind of work through that in your calculations after you analyze your patient population. Subsequent annual wellness visit years, the reimbursement, of course, for the G0439 is less than the other two codes, but still not inconsequential. Again, the same process or same tests brings in about $240 for a male, $261 for a female. But now you're taking it through all the other Medicare patients. I'm guessing somewhere in the neighborhood of about 500. Certainly depends on whether your practice is where it's located, what the age of it is, whether it's mostly working class, non-retirement community, or if you're looking at a retirement community, you can imagine the difference between New Jersey and Florida. For 500 people, if you had that many 500 Medicare patients in a practice, and that's not an uncommon number, it would be about $126,000. And that'll buy a couple of hamburgers at McDonald's. So for a total of 560 Medicare patients, that'd be about $145,000 of potentially additional money to the practice. And that's, excuse me, that's a nice chunk of change. So one of the impediments to doing this, of course, excuse me, is the need to make sure you're not providing a service that you're not going to get paid for. And the way to do that is, of course, check eligibility, and not only eligibility for Medicare, but check whether they've had these services in the last year or 2 years, depending on the service, or even 3 years. So there are a variety of ways to do that, and you want to make sure that you have that opportunity. Now, we've had some providers say, well, we don't have time to do that. But on the other hand, if you don't have time to do that, then there's not much Medicare can do to help you beyond that. You have to take the time, and you have to have the system set up so that you can do those checks, and you can, in fact, get paid for what you provide. Medicare has developed a preventive services checklist. This is a FAQ from their website where providers have said my patients won't follow up on routine preventive care. I think this again goes back to education. I think that we as providers have to make sure our patients understand that they are receiving a very significant educational service. In many cases, it may help find something that a patient didn't know about and be able to receive treatment. Those are real tangible to the people who had a disease or had an issue that they were able to find on these preventive service checklists, if you will. I gave you the link, but I'm going to show you what they look like. There's one page, we've split it into two for the slides, but it allows the patient to follow some of this. And it may also help prevent a patient who happens to be a snowbirder going to Florida versus New Jersey from getting a service up here and then going to Florida and trying to get it again, or vice versa. So pretty helpful. There's the bottom of that same document. You may or may not choose to use it, but I want you to be aware that it is something that CMS has created in order to help with the process here. The 27 Medicare preventive services that are offered, the screen looks like this. I've given you the link at the bottom there, and you can go to these various 27 boxes to get more information about this. There's my contact information if you have questions. We've been doing billing for 27 years, so we've seen a thing or two, as they say on TV. So if you have any questions, I'd be happy to answer them.
I'm going to open up. We do have a couple questions submitted already, but folks, if you have any others, we're going to get to them now one at a time. Rich, the first question, how can it be IBT for CVD if you can only bill a 15-minute code annually? That would not be intensive in my mind.
Well, you ask an obvious question, but all I did is restate their goals. I didn't pass judgment on it. I agree with you that in some cases it may not be enough, but that's their program, and I think probably in the overall negotiations as these programs come to fruition, there was some concern about providing the service, but perhaps it could be too expensive. I'm afraid I don't have a really good answer for that one.
Okay, moving on. So tobacco counseling can be provided by a specialist, correct?
Let me go back to that. If it doesn't say primary care setting, then they can do that, yes. If it says primary care setting, then they would not be able to do that. However, having said that, we are in the midst of an appeal process. We have as I mentioned earlier on, we have a physician who's both a cardiologist and has a significant amount of his practice that is primary care as well. And he has provided some of the cardiovascular preventive services, like I think it's the G0446. And Novitas has found a way to deny that, saying he's not a primary care physician. We're in the process of trying to get more information, although I think all of us will recognize that Novitas is probably, most of the MACs are not very cooperative in giving us the exact reason. So we're trying to find out how or why they're doing it. Is it based on their taxonomy code? Is it based on something else on the provider enrollment application? But in any case, we've gotten our first round of first appeal denials. We're in the process of going to the second level, and I fully expect it will end up at the administrative law judge level. So I think my point here is that just because they're denying it, I think it's probably worth fighting it a little bit with some logic. And I just kind of took this on as a crusade, because it strikes me as sort of crazy that a cardiologist wouldn't be qualified simply based on the wording in the deal here, where it says qualified primary care physician or other primary care practitioner in a primary care setting, because he has both. He does both primary care and cardiology. He has referrals from other physicians, and he has his own base of patients in primary care. So we're going to see where that goes. I suspect it's going to take a while to play out. I'm sure we'll get our second level denial here as we begin that appeal process. For those who are following the administrative law judge portion of this, they've been backed up for about 2 or 3 years. I think they're trying to get rid of that backlog. But we're going to go all the way. I'm going to see where that goes. It just kind of irritates me that they've taken that approach, and I don't know if that's a Novitas mistake or if we're going to lose in the long run. But we're going to do it. It's not a lot of money, but it's the principle of the thing in this case.
Okay, why are CMS and commercial insurance companies fighting preventative services at the same time CMS is complaining about adoption rates are so low?
That's a really great question, because there's a real dichotomy out there. We have a provider who was audited by Horizon. Actually, I have 2 clients that were audited by Horizon because their profile for doing the well visits was higher than their peers. And the point you made is right on, as far as I'm concerned. The insurers say they want these services to be provided, but then they chose to audit these physicians because their profile was so much higher than others. You know, it's sort of well, I can't say some of that stuff in public, but it's just an oddity, and I think you make a great point, and I probably said as much as I can say. I don't understand it either. We fortunately came out of the audit pretty well, but it was just a ridiculous reason to do an audit. Tell us you want us to do it, then when we do it, we're going to punish you by going through an audit. Crazy.
Okay, is it true that AWV is an initiating visit for chronic care management services, and isn't CCM another missed billing opportunity?
Yes, I thought about adding CCM into this, chronic care management, for those who may not be familiar with the acronym. You know, much of this has been moving pretty quickly. Now, preventive services have been in place for, gosh, 5 years or longer, and they've added to those what was out there initially. And now CCM came into effect, I guess it was last year, and then they added 2 codes this year. And then on top of that, they've got the CPC Plus and how that plays in with attributed to patients. So the complexity of doing all of this and knowing what you're going to get paid for, because if you're attributed, then chronic care management's part of it, and you get all these different permutations, if you will, with what qualifies and what you need to do for MIPS and MACRA. Near as I can tell, we may end up with a PhD in how to figure out quality for Medicare patients. I don't know if that answers the question, but hopefully.
Okay, I have one more. Can doctors bill for Medicare Advantage non-FFS patients for the new to Medicare first-year testing?
Medicare Advantage plans are required to provide the same services as traditional Medicare. The only thing we've seen is that, at least early on, those plans didn't use the Medicare traditional codes. So the way to figure that out is to contact the insurance rep or the customer service and ask the question if they offer that, and if so, which code. But we're seeing more recently some of these Medicare Advantage plans are using the Medicare G codes. So it's been a little easier to get paid.
Okay, folks, if there's no other questions, I'm going to close the webinar. Again, if you have any questions you'd like, you can get in touch with Rich directly. You have his contact information, and the presentations will be out later today or tomorrow morning at the latest. Thanks so much for attending. Have a great day.
Thanks, folks.